TopMedTalk.
Well, hello and welcome to TopMedTalk. We are here at the annual meeting for the American Association of Nurse Anesthesiology in beautiful sunny San Diego. I'm Desiree Chappell, co-editor-in-chief and lead anchor for TopMedTalk. And it's really been a wonderful experience being out here over the last couple days. Lots of buzz at the meeting. Hopefully we're going to be talking to some of the leadership here to see how many people have shown up for the meeting this weekend. But lots of great content and camaraderie happening here at the meeting. Now, I am a CRNA myself, so I'm very proud to be here at the AANA representing TopMedTalk, and it's great to be able to have the opportunity to sit down with colleagues and share a little bit about what we do in the world of nurse anesthesiology here in the U.S. So this year, I'm joined once again by my co-host and colleague at NorthStar Anesthesia, which we'll talk about more in just a minute, Randy Moore. Randy, thanks for sitting down with us.
Thank you. I think co-host is a bit of a stretch.
Oh,
I'm more of a liability on a stool, but happy to help in any way that I can.
No, guest commentator, I think, would be
How about
be
that?
good.
Yeah. Village idiot. Whatever.
Stop it. Well, we were able to sit down last year and had lots of great conversations from the AANA, so we thought we would do it again. So what I also am, besides a CRNA practicing, I'm also Vice President of Clinical Quality for NorthStar Anesthesia. Randy, why don't you tell our listeners a little bit about your role?
So my title is Chief Anesthetist Officer. So I work with the CRNA team, which represents about 2/3 of our overall workforce. So we're in 24, 25 states, 200 facilities across the United States, and have all in about 4,000 clinicians. Yeah. And so my role is to partner with the physician leadership and the operational leadership of the company to build an amazing and resilient anesthesia staffing company.
Yeah, it's great. And one thing that we get a lot of questions about is like, what type of anesthesia do we practice and how do we practice, what type of models? And I would say that we span the gamut, right? We
everything
in
under
the spectrum.
The sun. Yeah.
Every which way you can think to do anesthesia and where you do it, that's what we do. Well, it is a privilege to be able to sit down with the CEO for NorthStar Anesthesia, Adam Spiegel. Adam, thanks for joining us again.
Well, thanks for having me, Desiree.
Yes, I feel like we get a catch up about, once or twice a year, really, the AANA and the ASA. In the years past, we've always talked about kind of the state of the union, what things look like in the world of anesthesia from your perspective, from an executive level in the world of anesthesia management here in the U.S. It's a really important perspective that many clinicians probably don't always hear, especially frontline that are sitting in the OR. So I really wanted to have you back to talk again this year about it. But for our listeners, why don't you tell us a little bit more about yourself?
Sure. I'm CEO of NorthStar Anesthesia. Randy already told us all about NorthStar.
Sorry, steal your thunder.
Exactly. But I've been here at NorthStar for about 6 years. Prior to that, I spent about 25 years in healthcare, primarily working for a company called the Advisory Board, which worked with hospital senior executives doing consulting, research, and technology services.
Yeah, that's great. So coming into the anesthesia space, you're pretty familiar with it a little bit?
So I certainly was familiar with anesthesia.
Yeah.
Certainly have gotten, in the last 6 years, a lot deeper
You've gone very
the anesthesia space. So
yeah.
I do feel like I get lots of locum requests, despite having no clinical experience. Every once in a while I feel like I should answer yes to one of them, but I'm not quite there.
Yeah. Well, I think it'll be good. We haven't done much of this in the past, but maybe kind of like stepping back a level from not just anesthesia, but more of a healthcare perspective. I think you can lean on that just a little bit. So looking forward to that today.
Happy to do so.
All right. And we also have a guest join us today, Tracy Young. Tracy, thank you so much for joining us.
Hey, thanks for having me, Desiree.
Yeah, we wanted to invite you into this conversation to talk about the business of anesthesia. I know this is something that you're very passionate about and involved in the space. So for our listeners, why don't you tell us a little bit more about yourself?
Sure. So my name is Tracy Young. I'm from South Louisiana. Been a CRNA for 23 years, and I've been involved in the business of anesthesia since 2003, where I founded YPS Anesthesia. And over the years, YPS grew slowly and methodically and merged with a company called Emergence Health back in 2020, where we created Essential Anesthesia Management as a management arm for the two organizations. And my current role is Chief Operating Officer, where oversee the practice management functions, scheduling, some credentialing departments, and really setting up systems and processes where our facility clients could get the best anesthesia departments that we can provide to them. And outside of the business world, I'm also the Region 7 Director for the American Association of Nurse Anesthesiology for 3 more days. And I'd be...
Congratulations on that.
Well, I'm not sure. I'll be transitioning into the Vice President.
Oh, that's right.
In 3 days.
Well, congratulations on that new role, and thank you for the commitment to the AANA and supporting the region for sure. Well, we thought, and actually this is Randy's idea, to talk, to have kind of both the perspectives that we have from, a national, very large anesthesia company, and then Tracy hearing, maybe we can hear a little bit more about what Essential looks like in the companies that you work with, what the footprint is. But we thought it would be good to have those two perspectives. So why don't you just tell us a little bit more about what the footprint looks like for you?
Absolutely. So we consider Essential a regional anesthesia management company. We have...
And not regional anesthesia like doing blocks.
not ultrasound regional, which we do plenty of. We're in 6 states currently. Louisiana, Texas, and Oklahoma are probably our most concentrated states for a number of providers, but we do a little bit of business in Mississippi, Arkansas, and New Mexico as well. We're in 124, I believe, maybe 126. I've been here a couple of days. We may have started a facility or two since I've gotten here, with about 1,400 anesthesia clinicians. Really excited about the anesthesia market space. It's challenging at the moment, but everyone loves a challenge, right? It's why we get out of bed each morning. So
yeah.
The fun and the fun part of this is we are actually competitors.
Thank you. Call that out, Randy.
Heated competitors.
We're transcending all of that today.
Yes. And my job is to make this as awkward as possible. So
why don't you start off with the first question then, Randy?
Well, it's interesting. I mean, there's very real examples of, Tracy and his team walking out of a pitch and a NorthStar team walking in. And I think the takeaway, though, is to be more serious is like, yes, we are theoretically competitors, but we admire a lot of what you all have been doing. You all have a great reputation in the marketplace. And while we are competitors, I think it's a mutual admiration kind of relationship in terms of, and we often have conversations about what are you seeing? How are you thinking about certain problems? We talk about, Jason and I will talk about some certain business problems and he'll give me some insight, and maybe I might give him a little insight in terms of how we think about things. So it's definitely we might be competitors, but we definitely see things in a very similar way.
Yeah.
Yeah, I agree. And I echo the sentiment as well, too. And it's always fun to be in a random city somewhere and do a pitch to a board at a hospital and walk out and to see these guys walking back in. And we give each other hugs, tell each other hi. The anesthesia space, we talk about competing, but really all we try and do is put our best foot forward, give the hospitals the best deal for the best services that they can get in the most efficient manner. And we're all doing that. And we recognize that sometimes we win, sometimes we come in second, sometimes we come in third. Yeah. But we're just all trying to put our best foot forward and making sure that the hospitals and the patients and the communities are able to get the anesthesia services.
Adam, why don't we pull this up just a little bit and talk about from the general overall business of anesthesia and the current things, where are things going right now? Tell us a little bit about the market here in the U.S. from your perspective.
We've gone from what could be described as total chaos to, a little bit more stability. We're starting to see. The interesting thing is, if you think about maybe, call it 18 months ago, a lot of focus was just in, are we hitting the points of service that the hospitals are asking us to do?
Mm-hmm.
And I think hospitals were increasingly asking everybody to hit more points of service, to do more. And a lot of our focus was, how do we find just people to throw into rooms and get it done? And I think what's happened over the last 18 months is that has really stabilized. Part of that has been there are more anesthesia providers in the market. I think a big part of that is hospitals are rationalizing the amount of ORs that they want to run.
During our last conversation, we were saying as we were emerging from the COVID years, it was, let's say yes to everything at any time to get this done because we need those volumes to come back up.
Yes. And I think if you look at hospital financials, what you're seeing is that there's a big disparity between, there are a lot of hospitals that are actually doing very well financially now, and there's still a lot of hospitals that are doing very poorly. And when you look at those different facilities, a lot of the ones doing well have started to take a much more rational approach to how they think about the OR. And I think the we'll do anything for everybody is still the people who are doing very poorly. Mm-hmm. So on average, hospitals are doing significantly better. Their margins are back to, call it 2-3%. That's still historically low, but it's now very bifurcated. You have hospitals who are back to the healthy 4, 5, 6% margins, but then you still have a lot of hospitals that are losing money. And a lot of that comes down to running efficient hospitals, as opposed to just kind of doing whatever the surgeons are asking me to do. And I think when you find that hospital executive who has shifted from the grow at any cost to now I've got to cut costs, they start to rationalize the way that they approach anesthesia, and it makes life a little bit easier for us. And so what we're finding is that our focus has shifted from sort of desperately trying to find everybody and put out a bunch of fires to getting back to the basics of, look, as an organization, we have to add value.
Yeah.
And where we do that is running our practice well. So I think getting back to the basics of good revenue cycle, efficient sites, making sure we're retaining our top people, that is much more of the focus now than certainly it was 18 months ago.
Yeah. And Tracy, from your perspective, I mean, does this sound very familiar to you? Obviously, the same challenges in the past, but how are things looking from your perspective?
Absolutely. Yeah, we're seeing some of the same things. So we're seeing some departments really stabilize out from an anesthesia provider standpoint. Some of the compensation changes are becoming a lot more stable as well, too. We got in a period of time where we were almost renegotiating hospital contracts and provider contracts every 6 months. And we feel like that's kind of stabilized out in the marketplace. But the big thing that Adam mentioned, and I agree with 100%, is hospital margins are really constrained right now. Coming out of COVID, they were flush. All these hospitals were flush with cash. And the economic engine of hospitals are the operating rooms. And you can't really run operating rooms without anesthesia providers. So what we started seeing in RFP requests and we started seeing in hospitals when coming out of COVID is, hey, we want to start with 12 rooms and we want all 9 of them going to 5 and we want 7 of them going to 7 p.m. because on the whim of surgeons, they'll open up rooms and they want to make sure anesthesia is there for it. And when they were flush with cash, that was kind of okay. But now in this time of where the cash isn't quite as prevalent and they got to be better stewards of their financials, we're starting to see some of that, some logic being applied to that. We're looking at utilization metrics. We're looking at return for dollars, right? Do you really need to run 6 rooms till 7 p.m.? How do you change the schedule from this really horizontal schedule with a bunch of rooms coming down early, but still having a bunch of rooms running late, or potentially this gray area in the schedule where you have anesthesia providers at a premium sitting around for 5-6 hours waiting for a surgeon to come and start after hours cases at an additional premium. So they're looking at efficiency a lot more. It's incumbent upon us a lot of times to help educate them on that and help show them where they can gain the value, where they can be more efficient as a good partner in anesthesia. And I'm sure NorthStar is doing the same thing. What always cracks me up is RFPs, requests for proposals. We see some, it almost looks like a 5-year-old's Christmas wish list of everything they want from an anesthesia department. When you give them the price for it, all of a sudden they're sticker shock.
Yeah.
These proposals are always fun and interesting to do. And I see Adam nodding his head. I'm sure y'all see the same thing.
Yeah. How does that work, the conversation, having with the executive teams now? Do you feel like that's really shifted with our hospital partners and potential partners?
So I'd say it is moving in the right direction. What Tracy was saying, we're still seeing a lot of, which is, I want everything, but oh yes, and I also would like
the Cadillac.
I also like to pay less money, and that's like
really
life doesn't work that way. So we actually spend a surprising amount of time educating hospital executives on how the anesthesia business works.
Mm-hmm.
And I think, you have an array of leaders. Some of them listen, they get it, they incorporate it, and some don't. And I think that's makes this space very challenging right now because it is still very expensive to run anesthesia. And when you have a market where wages are rising and, we're finding the same thing as Tracy, which is they are starting to stabilize, but, they're still at very high levels.
Yeah.
While reimbursement is declining, it means that hospitals are spending an increasing amount of money on anesthesia, and they don't like to do that.
Yeah. So 2 things that, and Randy, jump in whenever you...
I think for the listeners who might be not as close to this from the business perspective, they might be asking themselves, like, well, wait a minute. In a rational economic model, if your revenue is going down, why would the provider cost not go down? And it's the exact opposite. And I think, Tracy, you alluded to this in terms of the operating room being the economic engine, but I'd love to hear both of you kind of explain the wonderfully weird world of anesthesia subsidies and why they exist and how this is impacting hospitals.
I'll take the first swing. I see Adam looking over here. The provider compensation has been going up since COVID. We lost a number of providers during the COVID time that either retired, went out of the workforce. And also we've started spreading out the base of our providers. We're doing anesthesia in dental clinics now. Every GI center basically in America now has anesthesia services. So we're pulling providers outside of hospital-based services, and they're providing anesthesia all over, office-based and everything else. So we spread out the base, decreased the number of graduates for a period of time, especially on the CRNA front. We switched from a master's degree to a doctoral degree as an entry level of practice. And that delayed some cohort graduation, sometimes 6 months to a year. You couple that with the retirements. It's a supply shortage that Adam mentioned earlier. There's just not enough providers. So
and that's
everyone,
sorry to interrupt, but that's both on CRNA and physician side, correct?
That's correct. The physician side, to me, came to the market a little bit later than the CRNA side. We started filling it earlier on the CRNA side than we did on the physician side, but it's there as well.
Okay.
And so what we're doing is, in the marketplace, if a hospital has 5 CRNA job openings or 5 physician job openings, every hospital in town probably does as well too, and all the neighboring towns. So we're competing for the eyeballs for the same spots. And if your job looks like everybody else's job, you're more than likely not going to find someone. And the marketplace has shifted to, we're real big on culture and making sure that our providers love working for us. We take care of them. We treat them like family. That can only go so far when they're looking at jobs and the next job is paying $50,000 more a year for the same type of work. So it's becoming a very price competitive, and the price just keeps going up and up. And as we alluded to earlier, it's starting to stabilize a little bit, but it's all based on supply and demand. So the demand is still there coming out of COVID, but the supply of the providers just isn't there to meet the demand currently. I'd love to get into some of my thoughts about how that's going to change in the near future, but I'll see if Adam has any thoughts to add.
No, I mean, Tracy's explaining exactly the issue, which is when you have this supply problem, it started really on the CRNA side. And I think a big part of that is actually expanded scope of practice. And I think when people are looking to provide more economic models, the move was to increase the number of CRNAs. That especially was in play in the ambulatory surgery space. And I think the big thing that happened in COVID that changed some of the demand dynamics is that more and more surgeries went to ambulatory surgery centers. Hospitals assumed volume is going to come back. That went to the surgery centers, and it didn't come back. So you have surgery centers who suddenly needed more business. They were much more focused on, at a surgery center, hiring a disproportionate number of CRNAs. And when the hospitals asked for more rooms as well, that's when you run into this big demand issue. On the physician side, I think what we've seen over the last, that's been a little bit more recent, is a lot of the physician-led groups are finding themselves, gosh, I'm working 70, 80-hour weeks, and I could just take a job at a hospital and work 45, 50 hours and make the same amount of money. Yeah. Why am I working these crazy hours? And what that did was took a bunch of workers weirdly out of the workforce, because if you're working 80-hour weeks and you suddenly move to 40-hour weeks, is as if a physician retired.
You're working at 2.0. You've lost it.
Yeah, it really is true. And we see that in a lot of the very physician-owned practice markets where you saw a lot of smaller practices. A lot of those physicians just said, hey, I don't want to work this hard anymore. And that has actually created, sort of, to Tracy's point, a couple years later, the same kind of supply problems on the physician side that we saw on CRNAs as well.
I don't know if all of our listeners understand how it works, at least here, definitely in the U.S., it may be other places, when it comes to how we are paid as team anesthesia. Can you do a little bit deeper dive on that for us?
Sure. So from a U.S.-based perspective, our reimbursement is going to come from patients themselves, from commercial payers, and from insurance companies. The reality is that if you think about the average CRNA and physician, only about 50% to 60% of their compensation is actually paid for by those patients. And the reason behind this is, look, like if I am a level 1 trauma center, to the most extreme example, if I have a patient come in from a car accident, I need to have that staffed 24 hours a day. I may get no car accidents. So therefore, I'm paying anesthesia resources to basically sit there. There is no reimbursement coming in from patients because patients didn't get hit by cars that day. So from that perspective, you have to, as a hospital, pay for those services. Because reimbursement has not kept up with costs, we're in this weird world where if you want to have anesthesia coverage, the hospital is going to have to pay you more money beyond just that reimbursement. So if you think about that, the hospital has to make up that 40% that we're not getting from Medicare, commercial payers, or the patients themselves.
Yeah. And as team anesthesia, we're paid separately. So the facility bills and they do all their billing and they get the revenue from the insurance company CMS things, correct?
So just as an example, if I'm doing a orthopedic surgical case, it is the facility fee. They're probably going to get, from a commercial perspective, somewhere between $40,000 and $45,000 for that case. The orthopedic surgeon, so the physician fee, is going to be $25,000 directionally. The anesthesia fee for that is going to be maybe 10 units, which will get
what's a unit?
$50 a unit. So you're looking at, on average, somewhere between $500 and $800 in anesthesia. So that's where the economics go. So from a hospital perspective, they're obviously making a lot of margin on that facility fee, the making margin on that physician fee. So, the $800, they need to reimburse that because it's actually costing probably $1,200 to actually do that case. So they're going to pay, we're going to get $800 from the patient, and they're going to pay that extra $400.
Yeah. So cost is going up because there's supply-demand mismatch. So we go to our hospital partners and say, you're giving us a subsidy to support this, but hey, I know I just asked for it, last month or 6 months ago. Guess what? There's a race to the bottom in this market. And how does that go, Tracy?
Those conversations are always really, really fun. So yes, you go out, you need to get an increased subsidy, you need to get it from the facility, but we always try and make sure we pull any other levers that we can as well too. Those levers are typically efficiency. Do we need 3 people on call for that car accident, for that person to get hit by a car that day? Maybe we can do it with 1.5, maybe 1 person in-house, half person at home. There's a lot of other efficiency levers that we can pull. We can look at from staffing models, again, talking about schedules, how horizontal they are, how vertical they are, OR utilization metrics. So when we go to the table with them, it's not just saying, okay, we got to give raises, give us more money. We try and explore all other options. We give them visibility as well, too. And if there's a good rationale, like, for example, if it's for CRNA compensation increases, because 3 of our CRNAs just left to go across town for another hospital, and we know what their pay rates are, we can look at those and have a transparent conversation and say, I know you don't want to pay more, but this is going to continue to happen. Yeah. And guess what? Every time we bring in a temporary worker to replace those, we're paying another 30 or 40% premium on top of that again as well. So having those conversations, being logical about them, and being transparent. While they're not fun, they're necessary.
So I'm hearing loud and clear that the workforce shortage is probably the most substantive driver of performance. There's other things out there, including reimbursement, and the workforce issues are not resolved and probably won't be resolved next month or maybe even next year. There's both a conversation about what do we do now and what do we do 3 years from now to address that. How are you all thinking about that? Adam, you start with, how are we addressing, and we are seeing what I think is some early indicators of stabilization potentially, and that's typically market by market. What's the interim play, and then what's the more longer term play here to get a more sustainable trajectory?
Yeah, I think for us, we've really looked at training as one of the things that we need to be really good at, because in a world where we're going to continue to need new CRNAs to be part of the workforce, what can we do to kind of move upstream and support new programs? For programs that exist, how do we get students into our sites so that we could actually provide that education, we could be hands-on with them? And it's not just CRNAs, it's physicians as well, increasing the number of residency programs, because this problem is not going to go away. And as part of what we do, I think our responsibility as an anesthesia company is to be thinking 3 years out of, hey, for every program that we're starting now, in 3 years, it's going to make our lives a little bit easier. So I think a lot of this is about how do we make sure that the pipeline, we can do everything we can to support the pipeline. And I don't think historically large practice management companies have done much there. I think they've relied on the schools themselves to produce their future workers.
Tracy, anything?
Exactly the same thing. I think we're affiliated with 16 training programs across the United States. We consider it basically an essential part of our workforce going forward. It's an investment in those students and residents, making sure they get the best training that they can. And they've training at our sites, so they get exposed to our culture and they get exposed to how we treat people. And obviously that's a great recruiting tool for us. The next step for us is really, we spend a lot of time and energy thinking about, talking about, and trying to solve the recruiting issue. We have an internal recruiting department of, I think it's 3 FTEs, and they do an amazing job. They're here at this event, networking, recruiting for us. But what we often forget about and don't give enough attention to that we're really trying to stay focused on is retention.
Yeah.
Retention is just as important as recruiting. Your listeners would be shocked how expensive it is. For every time you get a resignation of a clinical provider, the cost is extremely high for that.
Just ballpark, what's that look like?
Under best circumstances, probably 6 figures. If someone gives you 90 days notice, you start, unless you have someone in the pipeline already ready to start and have given notice to their employer for 90 days, that's an ideal situation. That rarely happens, right? Because you don't know when you're going to get resignation sometimes. And not all resignations are bad. Sometimes people need to move for family commitments.
Yeah.
So when we talk about turnover, we try and segregate turnover into different categories. Categories where we could have done things better. Categories where, hey, look, life circumstances happen and this provider needed to move on. But retention is so key, the cost. So another provider, it may take 120 days plus to be able to bring in another CRNA or another anesthesiologist. You're short-staffed during that period, bringing in locums or paying your other staff overtime. Those costs add up significantly. And then the man-hour and the cost of getting credentialed, getting providers onboarded, getting them oriented is an extremely costly proposition every time you get a resignation. So retention to me is equally as important, if not more, than actually being able to recruit.
Yeah, you talked a lot about why culture matters. And I do think, you think about students coming out of school, I think too frequently they look at just the price and say, hey, I can make 5% more at this location versus the next location. I think people very quickly learn the importance of culture once they're actually at a facility. And, I think a lot of that really comes down to individual leaders. So Tracy's exactly right. The expense of turnover, what you don't want is a sieve where you're bringing people in the top and they're falling out the bottom. And the best way to stop that up is having strong leaders. So great chiefs of anesthesia on the ground that people want to work for, that people feel like they can continue to grow underneath. And that is a big investment area that we've had to, spend time on, because making the investments in leadership now prevent that turnover later. And I think that's a really important thing for us to do.
Yeah, that's a great topic. We just did a survey of all of our clinical providers, all of our FTEs, and any PRNs that are part-timers that work a significant amount by site with net promoter scores, comments, what's the biggest strength of your workplace environment, what's the biggest weakness, getting that data in. And you nailed it perfectly. It's really about site level leadership. We could do a bunch of things culturally from a corporate standpoint that moves the needle, but the biggest needle mover is having great leaders that people want to follow, want to work with at each site level. That's where you get the biggest bang for your buck, for sure.
Yeah. Randy and I talked to Mandy Spitzer, who is our new director of academic affairs for NorthStar yesterday, and did a little bit deeper dive into that. So I would definitely recommend listeners take a listen. So I want to pivot just really quickly, because last year we talked about a lot about locum providers or 1099, which I'm going to have you guys talk a little bit more about that and explain that. But do you feel like we're reaching a tipping point right now? Because so many, definitely CRNAs as physicians as well, went into that 1099 locum market during COVID, and I feel like maybe the tides are shifting a little bit. Randy or Adam, from your perspective, what do you think?
Again, I think you're starting to see it's very market specific. But I think in a lot of markets, what you're finding is, one, being able to determine exactly where I want to work, the shifts I want to work, et cetera, as a locum, those days are starting to be numbered.
Yeah.
And you're starting to see people really understand, gosh, I can't necessarily get the shifts I want at the locations I want. So while I still might be able to make a lot of money, the cultural problems at some of these facilities make me not want to work there. So we are seeing certainly in a bunch of our markets, people raising their hand and saying, hey, would like to come back as a W-2. And what happens then is you get to the tipping point where then you can play a little bit more hardball with the locums and say, look, I don't need you anymore.
Yeah.
And then suddenly you start to see a bigger group of people start to come over and say, okay, well, if you're not going to pay me the locum rates, I'll take the W-2 rates again. So I do think you're starting to see that in some markets.
Yes.
I still think you've got a world where there's a number of markets where it's still Wild West, and people have 30% of their workforce that are temporary or not employees, and that creates it's really hard to create a great culture when a big chunk of your workforce isn't your employees.
Yeah, for sure.
I think this is where there are two things that can be true at the same time. One is that the anesthesia business is not that complicated, but it's also very difficult, which is weird, a little counterintuitive. So I think, I'll take my interviewer hat off and put my commentator hat on just for a second and say where we see success happening is when you look at sites that are doing the boring, important things over a sustained period of time. Those are the sites that typically are more resilient. They have lower turnover. They have lower premium labor spend, lower vacancy, et cetera. And it goes back to the other conversations about, the leadership is the most critical element that needs to exist in order for you to be successful at any given site. I think it's also sometimes people forget that this is all cyclical. We're in a cycle, right? The workforce is a cycle. What's happening in the business industry has happened before. Yeah, this is not unprecedented. And you're starting to see some of the, I think, frothiness around the locum market change in a meaningful way. Like I'm looking around here, and I can't swing a dead cat without hitting a locum company. But, 3 to 5 years in the future, I think that will be different because, you know what? I was around in 2008. What happened in 2008? Yeah. The locum market completely dried up. Yeah. Now, I don't know when that's going to be, but I know it will be at some point in time that we'll snap back. And I think that's where if someone has a crystal ball and has a concrete idea where that's going to be, please give me a call. Right. And let me know what it is so we can plan for it. But I don't know. I mean, Tracy, is that how you're seeing it? Or I'm not trying to lead the witness here, but, how are you experiencing this?
So,
in the marketplace?
100%. And to your point, and to Adam's, it is very market dependent. If we do a transition of a hospital from someone else and it's 70% locums, as we start recruiting and bringing on full-time people, there's a tipping point at around 50 to 60% that the folks that are there doing locums or start saying, okay, the music's going to stop soon, and I want to make sure I have a seat when the music stops. So we start seeing then that it all of a sudden you get a stable department pretty quickly. You just got to get that momentum moving. And the whole time we're having this conversation, I cringe every time I hear the word locums. Yeah, because so many of these CRNAs that call themselves locums aren't really doing locums.
No, they're not.
For 20 years in the industry, locums means you're getting in your car or your truck or an airplane and you're going somewhere far away. You're not sleeping in your own bed. You're working to provide relief for someone else. What we've seen in this last 2 years, it's been a shift where CRNAs are going PRN. They're quitting their full-time job. They're working PRN all around town, sleeping in their own bed each night, getting paid a premium to do it, and they're calling themselves locums. And in my opinion, unless the definition is just completely changed, it's still not locums. Most of them are doing PRN work, quite frankly, on a 1099 basis as an independent contractor. And that differentiation to me, and what we try and do in the marketplace, I'm pretty sure Adam and Randy do as well too. If you're going to be sleeping in your own bed and you're going to work PRN, you're probably going to get a little bit of a premium over what maybe an FTE will. However, you're not going to get a premium of someone that's missing their kids' baseball games and T-ball games by flying in across the country to give us relief and give us assistance. It's a different mindset and understanding the pros and cons of each, but really defining it correctly, in my opinion, is important. And we've done a poor job of that in the last couple of years.
Yeah, no, I'm so glad you dove into that a little bit more. I think that is really important. And people don't understand that. I think a lot of new grads who are like, oh, I want to get out and work locums and, just stay in my own little city and do whatever I want. It is a definite differentiation. What are you most excited about in terms of where we're headed as team anesthesia and in the healthcare market, like our position in that, Adam?
Yeah, I mean, I think what's always exciting is people need anesthesia.
They're always going to need anesthesia.
They're always going to need anesthesia. And I do think you're going to see surgical growth over the next few years. So that's great for our practice. It's great for what we do. I actually think, in a counterintuitive way, stabilization makes everybody happier because it allows you to focus on team. It creates a lot more cohesion. It allows us to have time to get out the form leaders and bring in new leaders that are going to be successful.
And I'll plug quality there too, and focusing on quality and research, all that good stuff.
But I think it allows for a much more sustainable world for every.
Yeah.
And I think while, the days of being able to name your price kind of thing may go away, and, instead of seeing 15% increases in compensation every year, it'll go back to 3 to 4% increases. I think everybody's going to be happier. because it's just going to be a better environment for people. And I'm starting to see that in certain markets where, compensation isn't out of control, but those happen to be our happiest CRNAs relative to ones that are in markets where, life is crazy.
Yeah. Tracy, what about from your perspective?
Well, I agree with that. I also agree with what Randy said earlier about things being cyclical. We've seen this before, and we've seen the other end of the cycle where we're oversupplied on providers. And I take a little bit of a probably counterintuitive or at least different view than most of the researchers. So if you look at the research right now related to workforce and what's going to happen to the next 5 to 7 years, they're predicting this shortage is going to continue for a while. I think a little differently, potentially. I'm not sure the demand for surgery is going to continue to go up as much as they're saying. We're doing more things less invasively.
Yeah.
We have pharmaceuticals out that are causing people to lose weight. Bariatric surgeons right now are they're putting their yachts for sale.
Yeah.
Due to the semaglutide and some of the other GLP-1s. Orthopedic surgeons aren't doing as many knee scopes.
Yeah. Spine surgery, they've said, is actually the volume is going down there too.
And that's just the tip of the iceberg. We're innovating in healthcare everywhere. And most of the things that we're innovating is not doing bigger surgeries. It's doing less and less surgeries and correcting things less invasively, potentially without anesthesia services. So I'm not sure that the researchers have it nailed just right on the demand continuing to increase. I could be 100% wrong. They're the experts. But I've taken a little bit of a counter view on that. And from a supply side, we've opened up tons of new CRNA programs all across the United States in the last couple of years. Those programs are just starting to graduate some of their trainees into the marketplace now. That's going to continue for the next couple of years. And residencies, match rates have reached all-time high for residencies in anesthesia 5 years in a row. So I'm thinking over the next couple of years, we're going to probably start to solve this problem. And within a year or two after that, there's a very good chance we may be in an oversupply situation again. And because we never really get it right, do we? It's a cycle of undersupply, oversupply.
Why we cycle.
That's why we cycle. We
pendulum swings, right?
We always try and get it right, but it takes so long to correct when we find ourselves behind, like we did after COVID, right? These are black swan events. What I'm talking about is not having a black swan event in the next couple of years that will force massive retirements or something else that we just can't even foresee, right? Because we don't know the future. But my hunch is we'll be oversupplied probably within 3 to 5 years. And within 2 years, I think we're going to be a lot more stable. And please welcome me back in a couple of years.
For sure.
And tell me I was wrong or tell me I was right.
Interesting prediction. I mean, I think, too, one of the things I'd love to, if we don't have the time today, but do a little bit deeper dive on alternative providers and different types of, sedation nurses and things like that to, go back into the GI suites and things. I mean, there's a whole nother spectrum of providers we could talk about. But anyway, I just wanted to say thank you guys so much for joining us here on TopMedTalk. Any final thoughts, Randy?
Well, I enjoyed the conversation and appreciated your insight and your perspective. Maybe end it where we started, which is at the end of the day, I think it's cool that we both are providing a very important need to the communities that we serve. And it's important that we don't lose focus on that and that, things are hard. But at the end of the day, it's leadership and foresight and courage. It gets us out of this stuff. And I am really appreciative of having the opportunity to have a conversation with you, Desiree and Adam and Tracy. And hope the rest of your conference goes well.
Yeah, fantastic. Thanks again, you guys. And thanks for listening to TopMedTalk. You can always find us on social media. Your favorite podcatcher, we are there. And check us out on TopMedTalk.com and find out all the great content that we're producing. There's a ton of it. So thanks so much for listening. Have a great day.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe. Check us out on YouTube and, of course, on social media. We're on Instagram, Facebook and X. Also, it's important to remember that TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that, and the way to do that is ebpom.org. Check out our website and find out about some of the incredible conferences we're going to be arranging across the year. ebpom.org.